Hello, so today we'll be talking about schizophrenia. Schizophrenia is a psychiatric disorder affecting 1% of the general population and typically arising in late adolescence and in early adulthood, Carlson 2004. Caradoc and Owen 2007 state that the Diagnostic and Statistical Manual DSM-5, typically used in the USA, and the Classification of Mental and Behavioral Disorders ICD-10 is used by the World Health Organization in classifying and diagnosing schizophrenia. These classifications use a categorical approach that defines a disorder as being either present or absent. An alternative dimensional approach involves viewing schizophrenia along a continuum and considering where along the continuum the individual symptoms lie. Caradoc and Owen 2007. De Song, Stone and Farrar 2000 indicate that diagnosis requires two or more positive, negative and/or disorganized symptoms to be present for at least 1 month. Positive symptoms include delusions, hallucinations, behavioral discontrol, and thought disorder. Negative symptoms include affective flattering, alogia, avolition, anhedonia, and attentional impairment, whilst disorganized symptoms include rambling of speech, erratic behavior, and inappropriate affect. De Song, Stone and Farrar 2000. So, functional neuroimaging for diagnosis, brain abnormalities in schizophrenia. McGuire, House, Stone and Fusipoli 2009 state that functional neuroimaging can be used to investigate the pathophysiology of schizophrenia. Brain region activity associated with cognitive processes and symptoms of schizophrenia can be detected using functional magnetic resonance imaging (fMRI). Functional magnetic resonance imaging scans demonstrated that resting neural activity and activation during cognitive tasks was abnormal in several brain regions of schizophrenia patients. These brain regions include the prefrontal cingulated and temporal cortex, the hippocampus and striatum, the thalamus, and the cerebellum. Some cognitive abnormalities are evident before the onset of schizophrenia. Individuals show abnormalities in the prefrontal and cingulated function, as well as increased striatal dopamine levels. However, these abnormalities are small in magnitude, making fMRI difficult to use as a diagnostic tool for individual patients. Psychotropic drugs and clozapine. McGuire, House, Stone and Fusipoli 2008 state that drugs have been developed for the treatment of schizophrenia which rely on preclinical animal models. However, these models rely on the understanding of cognitive processes and symptoms of schizophrenia that do not occur in animals. Antipsychotic drugs have been developed, including first-generation typical and recent atypical antipsychotics. Typical antipsychotics prevent dopamine production by blocking D2 receptors in the mesolimbic pathway and reduce positive symptoms. However, they block all types of dopamine activity, and this results in harmful side effects. Atypical antipsychotic drugs target D2 receptors in the limbic system, but not D3 receptors in other brain regions. Atypical antipsychotics have fewer side effects than typical antipsychotics. Clozapine targets multiple neurotransmitters and has proven to be more effective in minimizing symptoms than antipsychotics. However, there are several side effects of clozapine, including loss of white blood cells. Antipsychotic drugs are effective as they are relatively cheap to produce, easy to administer, and have positive effects on sufferers by lessening the symptoms. McGuire, House, Stone and Fusipoli 2008. However, Knorr 2009 argues that 1/3 of patients do not respond to antipsychotic drugs blocking dopamine receptors. Cognitive defects of schizophrenia. So defects in cognitive functions such as memory, attention, central executive, and problem-solving skills are related to schizophrenia. Dickinson et al. 2004 examined whether cognitive defects can be understood as a single defect, a number of defects, or a combination of both. Schizophrenic patients were compared to healthy controls when administering a hierarchical six-factor model of cognitive performance. Results revealed that schizophrenia patients' cognitive performance is mediated by a common ability factor. Schizophrenic patients demonstrated lower ability on verbal memory and speed processing compared to control patients. Genetics and schizophrenia. So family, twin, and adoption studies suggest genetics contribute to the onset of schizophrenia. For instance, Lichtenstein et al. 2014 found that first-degree relatives had an increased risk of schizophrenia. However, half-siblings had a lower risk than full siblings. Increased risk of schizophrenia was present for all family relationships, including offspring adopted away, with heritability being 64% due to genetic factors. Even though the study included a large sample of 2 million participants, all participants were Swedish, therefore results may not be generalizable to other countries. Additionally, there is low power in estimating heritability of rare diseases such as schizophrenia in twin pairs. The dopamine hypothesis of schizophrenia. House and Kapoor 2009 state that the original dopamine hypothesis indicated that excess amounts of dopamine caused neurons to transmit too many messages to the brain in schizophrenic patients. High dopamine activity leads to positive schizophrenia symptoms. However, a second explanation was developed, suggesting that it is not excess dopamine, but more dopamine receptors that lead to overproduction of cognitive messages. The dopamine receptor hypothesis is criticized as it is unclear whether increased levels of dopamine receptors cause schizophrenia or whether increased dopamine is the result of schizophrenia. Environmental factors of schizophrenia such as childhood trauma. Morgan and Fisher 2007 reviewed the relationship between childhood trauma and risk of schizophrenia in adulthood. Studies indicated that schizophrenic patients demonstrated a high prevalence of childhood trauma, such as sexual, physical, and emotional abuse and neglect. For instance, a population study of individuals aged 16 to 74 years with schizophrenia were 15 times more likely to be sexually abused at some point in their lifetime. However, some individuals are prone to develop schizophrenia following childhood trauma due to genetic susceptibility. FKBP5 gene moderated the effects of childhood trauma on psychosis symptoms of schizophrenia. Genetic and environmental factors such as cannabis. Caspi et al. 2005 conducted a longitudinal study to test the hypothesis that some individuals are more likely to develop schizophrenia as they are genetically vulnerable to cannabis. Findings revealed that the COMT gene interacted with adolescent cannabis use and predicted the onset of adult schizophrenia. However, these results may lack internal validity due to researcher bias, as participants there was no exposure information about the period 15 to 17 years of about participants. Psychological therapies for schizophrenia (CBT). Tarrier 2005 found that cognitive behavioral therapy (CBT) can result in clinical benefits for schizophrenia patients. CBT aims to identify and alter schizophrenic patients' irrational thinking by encouraging the patient to explain the concerns. The therapist makes the patient understand events happening in their life by using the ABC model. There is consistent evidence that CBT reduces positive symptoms and relapse rates in acutely ill patients. However, Kingdon and Kirschen 2006 found that CBT is not suitable for all patients, especially those who refuse treatment and are too paranoid to form trusting relationships with their therapists.